Tonight I will have the pleasure of introducing you to Dr. Jekwon Yeh, pronounced like hooray, yay, better known as Dr. J. If you could hold your questions during the presentation, we will give you a chance to ask your questions after the speaker has finished. Dr. Yeh will speak on Xofigo, which is better known as Radium-223, and Palliative external beam radiotherapy for bone metastasis. Also, I think he's going to sprinkle a few other things in here just to make things a little more interesting, but primarily he's going to talk about the more advanced stuff. We often ask, is this the magic pill? Maybe not, but for some people, Xofigo can come close. For those that have castrate-resistant prostate cancer and some bone pain, Xofigo can be a blessing. Dr. Yeh is a native of Orange County, California. He graduated from the University of California, Irvine, better known as UCI, with honors in molecular biology and biochemistry. He then earned his medical doctorate from Boston University School of Medicine. He served as chief resident in radiation oncology at Kaiser Permanente Los Angeles Medical Center, where he took care of thousands of patients with cancer. Dr. Yeh has specific expertise in the treatment of prostate, genitourinary, head and neck, breast, gastrointestinal, gynecological, central nervous system, sarcoma, skin, lymphoma, and lung cancers. I guess we don't need any other doctor, right? We got it all right here. So, he has extensive experience in intensive modulated radiation therapy, better known as IMRT, 3D conformal radiotherapy, and breakbeat therapy. He is a member of the American Society for Radiation Oncology, better known as ASTRO, American College of Radiation Oncology, ACRO, and the American Brachytherapy Society. Dr. Yeh has been the primary investigator of several clinical research projects in prostate, gastrointestinal, and brain central nervous system malignancies. He has published scientific articles in peer-reviewed magazines. Ain't that bitch? I lost my place. Now I've got to go back and look again. He has published, International Journal of Radiation Oncology, Biology, and Physics. He has presented many of his research projects at international scientific conferences, including the biggie, ASTRO. He has been awarded numerous basic science and clinical research grants. And in case many of you don't know, for all you Chinese people out there, he's very fluent in Mandarin Chinese. It's with great pleasure that I introduce to you tonight Dr. Yeh. Come on up there.
Thank you, Wes. Right. Well, thank you for having me here. It's really a pleasure to be able to speak with all the friends here we have at the Prostate Forum. So I kind of have two talks for today. The first one is on definitive treatment of prostate cancer. Okay, I'll be talking about brachytherapy and also external beam radiation. And my second talk will be for more advanced patients, talking about bone metastases and the sort of therapies that we can offer. Let me just grab that clicker really quickly.
Oh, sorry about that.
Oh, sorry, I should have had it. And I will be at Cruising for a Cure this weekend also. I will be the one who is giving rectal exams too, so for all you guys who are interested. So, this we pretty much covered, but at the Cancer Center of Irvine, we're a private radiation oncology clinic. We have one very linear accelerator, and that's what we use to treat patients. Right now we have about 30 to 40 patients on treatment every day. We also have a procedure center. We have an operating room there where I perform brachytherapy, which is the surgical implantation of radioactive materials into the body. And I'll be talking about that a little bit too. We also have an imaging center where we perform MRIs, CT scans, ultrasounds. We also have a breast center associated with us too. Full service mammogram, ultrasound, breast MRI, ultrasound guided biopsy. So we do have an excellent breast center. This is our waiting room. This is just some of the artwork that my partner, Dr. Takeda, has. These are done by an artist by the name of Ed Moses. Does anybody know Ed Moses here? Okay, yeah. That's some of his artwork right there. And this is our linear accelerator machine made by Varians. Basically, how this works is the patient lies down right here. This machine actually turns at multiple different angles and treats the patient. And also, we're the founders of actually something called the rectal spacer. This is a polyethylene glycol gel. Okay, if you look at right here, this is your prostate. Okay, this is the rectum right here. In between, I've inserted this white gel that actually acts as a spacer material. It pushes the rectum about 1.5 centimeters away from the radiation. So by doing this, I decrease the dose to the rectum by about 50%, really decreasing the risk of rectal injury with the radiation therapy. No conflicts of interest to disclose. So, as you guys all may know, not all prostate cancers are the same. Okay, we look at things like Gleason score, PSA, and stage. Overall, Gleason 6 is considered a low-risk cancer. Very little potential to metastasize or spread to other parts of the body. And then we have Gleason 7 cancers. Okay, PSA 10 to 20, these are classified as intermediate risk. Okay. High risk are patients with Gleason scores of 8 to 10, PSA greater than 20. Okay. So I hear a lot of things out there where a patient will say, hey, I was just diagnosed with prostate cancer. People told me to leave it alone. Okay. That's actually not true. Also, like you mentioned earlier, nobody is perfectly the same as somebody else. Okay. And why the Gleason score is important is because it actually differentiates benign or slower growing cancers with aggressive ones that can have a tendency to spread. And so basically, cure rate for low risk, very, very high, 95% or higher. Okay. Theoretically, the cure rate should be 100%. Okay. Reason being is sometimes with Gleason 6 on biopsies, patient may have a hidden Gleason 7, Gleason 8, Gleason 9, Gleason 10. Okay. When patients are treated with radiation therapy, all we have is by the biopsies. Okay. Oftentimes, that 5% of patients who happen to die from a Gleason 6 prostate cancer, most of the time they had a Gleason 7, 8, 9, or 10, something more aggressive hidden. Intermediate risk, still very good cure rates, 80 to 95%. High risk patients, about a 40 to 60% chance of a cure. Okay. Even with the high risk, not everybody dies from it. Okay. But one of the things is most high risk patients, they do have their cancer come back. And we all know the therapy for that is hormonal therapy. Okay. Hormonal therapy has its own set of side effects. You take it for more than 1.5 years, now you're at increased risk, heart attack, muscle loss, bone loss. So when patients actually die with prostate cancer, oftentimes they die from a heart attack, but a lot of that may be attributed to the treatment. Okay, so whenever you hear people say the government, or certain task forces saying nobody's really died from prostate cancer, dying with it, not from it. Okay, but in my eyes, if you have prostate cancer, you took hormonal therapy, and that made you had a heart attack and you died from it. In my mind, you died from prostate cancer. So in reality, I think prostate cancer, there's a lot more deaths that really are actually attributed to it that we just don't really know about. There's many types of radiation. There's IMRT, Intensity-Modulated Radiation Therapy, and I'll go into what that is. There's things like SBRT. SBRT is basically like IMRT, but we're just giving big doses in smaller, or fewer fractions. Okay. There's things like CyberKnife, proton therapy. I'm pretty sure people have heard of that. Who's heard of proton therapy before? Okay. So proton therapy has been out for a while. It's touted as something that's much more exact than IMRT. Okay. Which is true. The way proton therapy works is if I have a target right here, proton therapy will shoot at that target on target 100% of the time. But the problem with proton therapy at most centers, they don't use what's called image guidance, which means they're doing the radiation, but not really pinpointing exactly where the prostate is. So who really cares if you're shooting right here 100% of the time when the prostate's moving left and right? Okay. So now more and more research is going to proton therapy and adding image guidance to help decrease the side effects. Okay? But for now, to me, proton therapy, it hasn't been proven to be better than IMRT. A few years ago, they did a large study. It's called the SEER analysis, and they found that patients treated with proton therapy actually had more rectal toxicity than the patients who received IMRT, or external beam photon radiation. Okay? The most likely reason is they're not using image guidance. Okay? So there is a large center here nearby. What they do is they put a balloon into the rectum, fill it with some water, and they hope that, hey, that pushes the prostate into the same position. Which we all know that's not very exact. Okay? So with the type of radiation we do here with IMRT, we also do something called image guidance. I'll go into that. And there's also internal radiation therapy. There's high dose rate and also low dose rate. Low dose rate is pretty much abandoned at our center. In the low dose rate, you may hear where men have 100 radioactive seeds placed in their prostate. Half the time you get a seed into the bladder, a seed into the rectum. You can't remove it. It stays there, giving off side effects for over a year. Okay, so we've really abandoned that. What we do is a high dose route. Instead of putting 80 to 100 seeds, we actually use one high dose seed that treats the prostate in about 15 minutes. And then we'll talk about unsealed radiation sources like Xofigo. So what we do here at the Cancer Center of Irvine, we treat all patients with combined modality radiation therapy. Okay? They're treated with HDR brachytherapy. This is basically, I want you to think of it as large doses of radiation to the prostate. When you get a tan, okay, let's say you tan Monday through Friday, 20 minutes a day. So Monday through Friday, you have about 100 minutes of tanning. So you get a nice tan. But let's say you get 100 minutes of tan in one day. Now you got a big burn on you. Okay? And that's probably the best way to kill off the prostate cancer cells, is by giving them those big doses at once. Okay? You give small doses too frequently, and it's like just getting a moderate tan. You really want those big booms to help kill off the prostate cancer cells. And then we combine it with intensity-modulated radiation therapy. This, instead of using large doses, we use small doses of radiation. With this treatment, I don't just target the prostate. I target the prostate and the pelvic lymph nodes. The lymph nodes are the body's filters. There's literally hundreds, thousands of them in your pelvis. So when you have surgery, they remove your prostate, and they sample about 12 lymph nodes to see if there's any cancer inside them. Okay? So one of the problems with high-risk prostate cancers, Gleason 8, 9s, and 10s, what makes them so aggressive is that despite having an MRI that says everything's located to the prostate, having a negative bone scan, okay, that there's always that chance of microscopic disease in the pelvis that isn't seen. Okay? That's what's so difficult about curing high-risk prostate cancer. Oftentimes a man comes in, has a Gleason 9 prostate cancer, undergoes surgery, has a complete removal of the prostate, negative margins, no lymph nodes involved. Yet a year later, the PSA starts to come up. And it's because these microscopic cells here that have already kind of escaped are waking up now. So this is our schedule of how we do our combined modality radiation. We do an implant on the first day of the, one implant on the first week, another implant the second week, plus or minus a break. Most patients don't need a break. And they go on to the 6 to 7 weeks of IMRT to sterilize the pelvis and the prostate. The first step is to do a pre-planning ultrasound. The reason being is your prostate should be less than 50 cc's if you're going to undergo brachytherapy. With such large booms of radiation, if you have a large prostate, it can obstruct pretty easily, okay, and have a lot more side effects. This is how I actually implant the patient in the operating room. So at the Cancer Center of Irvine, we do about 8 to 10 of these implants a week. Okay, so we're quite busy here. In California, there's only 2 centers that do this routinely. It's UCLA and also us. How this works is, I have the template right here. The prostate's right here, the bladder's right here. I have an ultrasound probe here. I insert these hollow needles into the prostate. It takes me about half an hour to finish. By the time I'm done, I have about 15 needles evenly placed right here in the prostate. You see that? And I have a template here that sticks to your perineum. The patient's basically lying on their back from 7 a.m. until 1 p.m. They're given spinal anesthesia. No patient complains of pain. And then this is how the rectal spacer works. Basically, we inject polyethylene glycol, okay, between the prostate and the rectum. This is a picture of an MRI. This is the prostate right here. This is the belly up here, buttocks here. This is the right side. This is the left side. This is the prostate. This is the rectum. Notice here how I have this nice spacer material right between, kind of acting like a shield to protect the rectum from radiation. After I have those needles implanted, okay, I do a CT scan. The reason being is I want to know where those needles are in relationship to the bladder and also the rectum. And I have set safeguards for the bladder and the rectum. I know I can't go over this dose, patients are going to get injured. Same thing with both the bladder and rectum. We have set safeguards. And this is what the plan looks like, all right? If you look right here, this white circle here is the urethra. Prostate surrounds it. It's this thick red line. The rectum is right here, this pink circle right here. And see these different color lines? These are actually called isodose lines. They tell me what dose is going where. The further and further out, the lower and lower dose. So you see how my high dose is concentrated right to the prostate. You see this part right here? It's kind of bending away from the rectum. This is how I can bend the radiation away from the rectum to protect it. Okay? So this doesn't just go circularly treat into the rectum. I actually mold it away right here. And now the patient has these needles sticking out of them. I've designed the radiation plan. How it works is there's one high dose rate seed in here, Radium-192. It goes through the wires, goes through the hollow needles, treats the prostate, and comes back out. Then goes to the next wire, goes through that to the next needle, and does that with all 15 needles. Okay? Each needle takes about a minute, so in 15 minutes you're done. We do one in the morning or one in the afternoon. The reason why we split it is because giving you one large dose like that may give you a lot of side effects, so we split it into a morning dose and an afternoon dose to minimize the side effects. Okay. And as I mentioned earlier, we do an implant the first week, another implant the second week, and then we start with the external beam afterwards. What we also do is called image guidance. So before each external beam radiation treatment, I take a set of x-rays. Okay? Because on x-ray, only two things show up, either bone or metal. So I can take x-rays all day long, I'll never see your prostate. Put in gold markers like that, now I know exactly where the prostate is, now I know where to direct the radiation. For the external beam radiation, we also do a CT scan and MRI to form a map of the body. Okay. This is a slice of the pelvis. Okay, this is the belly, buttocks, this is the right side, this is the left side. The prostate's right in the center. See each of these finger-like projections? That's a different angle of the beam coming in, okay, and it converges in the center, so the highest dose is actually in the prostate. This is our treatment machine. This is a linear accelerator, and as I mentioned earlier, you lie here, this machine will rotate at different angles and treats the prostate. Most IMRT treatments only take about 15 to 20 minutes a day, and these are 5 days a week. Now, why do we do this brachytherapy? Okay, why combine it? Most centers out there, 99% of them, they just do external beam radiation alone. Okay, and that in itself is a very good treatment, but this is a study done by Dr. Zalewski, who's one of my colleagues at Memorial Sloan Kettering, and he basically compared the PSA control of patients who got external beam only and patients who got the combination HDR and external beam radiation. So right here we're looking at PSA control. This blue line are the patients who actually got the combined treatment. This red line are the patients who got external beam radiation alone. In this study he was looking at intermediate risk patients alone. So what you see here is time right here, 2 years, 4 years, 6 years, 8 years, 10 years. And this is probability of biochemical control. So it looks like the first 5 years everything is the same. Okay. But what happens after 5 years? The combined treatment patients actually maintain a cure rate. Okay, it stops here around 90%, it doesn't continue to go down. But look at here, external beam radiation patients, they continue to have failures even late, okay, which is scary because most of the time we tell the patients, if after 5 years the cancer hasn't come back, it's probably not going to come back. But looking at this, that's further from the truth. After 5 years, these patients are having late and later relapses. Okay? Same with distant metastases. Right here, there is definitely improved metastasis control with the combined treatment. With the patients who got external beam radiation alone, less metastasis-free survival. So there's some thought that with the brachytherapy, because I'm able to put that radiation source right to the prostate, there's a better ablative effect in killing off the cancer cells. When we look at the PSAs after treatment, the patients who had the combined treatment have much lower PSAs than patients who had external beam radiation alone. And this is just another slide. These are from my patients that I've treated at Cancer Center of Irvine. But it kind of tells you how important PSA is to controlling the cancer. Okay? There's a lot of talk out there, don't get the PSA, don't get the PSA. But we know that the lower your PSA, the higher your chance for cure. So why would you subject yourself to not getting a PSA, right? Look at right here, patients with PSA less than 10, highest chance of survival, 10 to 20 worse, greater than 20, worse survival. Okay. PSAs greater than 20 are worrisome for micrometastatic disease that's already spread to the rest of the body. So in general, cure rates, with our combined modality radiation, Gleason 6s, 97%. As I mentioned earlier, the reason why it's not 100, okay, is because there's always hidden Gleason 7, 8, 9s, or 10s that can manifest many years afterwards. Gleason 7 is a very high cure rate, 95%. Gleason 8s we do fairly well, 80%. The Gleason 9s and 10s still very low cure rates, okay, around 50%. With the Gleason 9s and 10s, aggressive therapy is very important. So now we're looking at studies about treating these patients with chemotherapy up front. Because normally chemotherapy is reserved for patients who are hormone resistant, metastases. But now there's research saying, hey, get that chemotherapy in early. It may alter things. So this is basically Memorial Sloan Kettering's data. This is their low risk, their intermediate risk, and their high risk patients. And basically, we have the exact same results at the Cancer Center of Irvine. So we're very proud of that. Our low and intermediate risk patients all have cure rates over 95%. Now let's talk about side effects real quick. With the brachytherapy, there's urination side effects, mild frequency, urgency, mild burning, bleeding in the urine. In terms of the rectum, maybe some diarrhea, flare-up with hemorrhoids, maybe some mild bleeding. Most side effects are mild. They go away within a day or two. Bleeding may persist for up to a week. May have soreness in the groin for 5 to 7 days. If you have any, it's normally very, very mild. After the procedure, we give you antibiotics, steroid medication, start you on Flomax. The reason being is when you get radiation, your urethra actually has a tendency to close down on itself and you get a weaker flow. So by taking Flomax, you open up the urethra, now you got your good urine flow. We'll also give you Prilosec because the Decadron can irritate your stomach. Radium to alleviate any burning with urination, and then pain medicines if needed. Most patients don't need a single pill of pain medication. And the downtime is very low. Most patients are doing normal activities the next day. I tell patients to think of this as radioactive acupuncture, okay, which is putting in needles in the prostate to get that radiation dose to really give booms of radiation to the prostate. Now, the external irradiation side effects are pretty much the same, but with radiation, you have 2 times when you get side effects. Once during the radiation, those are acute side effects. But many months to years afterwards, you can get side effects also. Okay? So radiation is different from medication. Most medications, you take it, you stop it, no more side effects. With radiation, many years later, you can have side effects. Fortunately, they're very rare. Only less than 5% of the time they actually have it, but we'll talk about those. So acutely, with urination, just like the brachytherapy, more frequent urination, maybe some burning, getting up more often at night, maybe a weaker stream. And as I showed you earlier, normally the urethra is nice and open. Okay, with radiation, it kind of gets inflamed, closes off, now the urine flow is a little bit weaker. In terms of the rectum, maybe some diarrhea, loose stools, bleeding, flare-up with hemorrhoids, and generally they're very mild. Okay. This is kind of a timeline of your urination side effects. Okay, so this is the 6.5 weeks of radiation, IMRT radiation. First couple of weeks, very mild, and they slowly progress to the real end. Even at the real end, mild to moderate, persist for about a week, and they resolve in about 3 months. In terms of your rectal side effects, radiation for 6 weeks, same thing, starts off very mild, slowly progresses, gets better in about 4 weeks. Now, long-term side effects, fortunately, are pretty rare. The ones who actually get these long-term side effects from radiation are men who've had the TURP, which is the rotor-rooter procedure. Basically, it's men who've had surgery to this area, so now they're scarring. You add on radiation, now you get more scarring. So some men may get a stricture if they've had a TURP. The chance of that, about 5%. What that means is the scar down, the urologist just goes in and dilates it, reopens it back up. Leakage is also rare. The only men who get leakage from our radiation are men who've had the TURP before. In terms of the rectum, the worst thing can cause is an ulcer. Okay? So the rectal spacer we've developed, it's specifically aimed at preventing late ulcers from forming. Maybe some bleeding, maybe some diarrhea. Okay, but most of the time these completely resolve on their own. And also decreased sexual function. So with surgery, you get a decrease in sexual function because the nerves are nicked. Okay? You can take Viagra all day long, you're not going to get any erection. With radiation, it's different. It's not the nerves that are being affected, it's actually the blood vessels. Over time, these blood vessels, months to years afterwards, actually scar down the scar. So less blood flow goes to the penis. Okay? But over half of these men, you give them Viagra and Cialis, opens up the vessels, and they're able to have erections. Okay? So that's one benefit radiation has over surgery is that most of our patients who do get the sexual dysfunction, it's not right away. If it happens months to years afterwards. But there's something that they can do about it. Most of our men do respond to Viagra after the radiation. Okay. What are the side effect rates? In terms of the rectum side effects, this is acutely. Acute side effects means during treatment and up to 3 months after. Everybody gets a little bit of diarrhea, 25 to 40% of patients get some diarrhea. Serious complications like ulcers during the radiation, 0%. In terms of the bladder, increase in urinary frequency, about 40% of men get that. Serious complications like a bladder injury, 0. Okay. Now let's talk about late side effects. This is 3 months after treatment. There's GI rectum side effects. Mild diarrhea in about 5 to 10% of patients. Most of these resolve with time. Serious complications like ulcers, okay, 0.3%, so less than 1% chance of rectal injury. These are patients who had the rectal spacer. That's why this rate is actually very, very low. In terms of urination, bladder side effects, mild complications such as increase in frequency, late, okay, meaning months afterwards, about 5 to 10%, still very low. Serious complications like a bladder injury, like a contracture, scarring, still very low, 0.4%. So overall, this is a very, very safe treatment, very, very focused to the prostate. Very little radiation to the bladder and the rectum. Okay. So that's the first talk. That's just on definitive treatment of prostate cancer. The second talk, I think, is a little bit more interesting. Now this talk is more for advanced prostate cancer. Okay. So this is titled "The Prostate Cancer Came Back. Now What?" Okay. So I'm going to do this in kind of a case form. Okay. So let's talk about Mr. P. Okay. 66-year-old male, hypertension, hyperlipidemia, nothing serious. In 2007, his PSA is 5.7. This prompts a biopsy. Shows a Gleason 4+3 prostate cancer. So right off the bat, we know this is an intermediate risk disease, Gleason 7. Bone scan was negative. He said, hey, I want this thing out. So in 2008, undergoes prostatectomy. The thing about the prostatectomy is now it shows a Gleason 8 prostate cancer. Okay. So this actually happens quite often where the biopsy doesn't really coincide with the actual path. Multiple studies have shown that there's at least a 30 to 50% chance of upstaging after the biopsy when you go to surgery. Because really with the biopsy, you're just sampling parts of the prostate. You don't know what the whole picture is. Okay? So that can happen. Lymph nodes were removed. None of them were involved. The patient did have extra capsular extension, meaning the cancer grew out of the capsule. And he also had positive margins, meaning the surgeon may have left some microscopic disease behind. So his PSA after surgery goes to 0.2. Afterwards it goes to 0.4. Surgeon gets worried and says, hey, refer the guy to radiation. He may have some microscopic disease because he had that positive margin. Let's radiate it and see if we can cure him. Okay. So in 2009, we treat him with radiation therapy. PSA goes down, 0.2, 0.1. Looks like we hit our target. But then what happens a few months later? It starts to come back up. 0.8, 0.6, 1.4. Okay. What's going on? I thought we hit the target and the disease was cured. What do we do now? Okay. And the reason why, the PSA comes back like that, okay, is originally he may have had some disease here, left over. Okay. We give radiation, these cells are sterilized, they die off. Okay. But with Gleason 8, 9s, and 10s, Gleason 4+3s, that grade 4 component, okay, every time I see that, I'm always worried, is there disease in the pelvis? Okay, so we may have calmed down what's going on here, but now these cells are waking up. So what do you do when the PSA comes up? Men always say, where's this PSA coming from? So what we do is we search locally, do an MRI of the prostate, evaluate for possible residual disease. If we see a lesion, we can, probably laser it. We can put a needle in it, maybe give some more brachytherapy. But after radiation and surgery, it's very unlikely that this disease is local, okay, especially with the Gleason 8. Then you search distantly, you do a bone scan, see if there's anything in the bones. Oftentimes, it's not going to show anything until the PSA is 20. Okay. So now we kind of don't know what to do. We don't know where the cancer is. We don't know when we should start therapy. So most of the time, nothing will be found until the PSA reaches levels around 20. If the PSA is greater than 1 after surgery and radiation, I almost automatically assume there's microscopic disease throughout the body. Okay. And this happens all the time. Patient gets surgery, has radiation, has a PSA coming up. We do the scan, nothing shows up. So what do we do now? So prostate cancer and prostate cells, they have testosterone receptors on them. Okay, so theoretically, testosterone is the fuel for the fire. By decreasing testosterone levels or castrating the patient, you can control the prostate cancer actually many years. These are medications like Lupron, Firmagon. But really, these hormonal therapies are just palliative tools. They're not curative. Median progression-free survival. Okay, that's just a fancy way of saying the ability to control the PSA or tumor from growing. Okay, about 20 months for hormonal therapy. Overall survival, how long a patient has to live. This varies. We've read anywhere from 2 to 3 years to 5 years. Okay. At some point, all patients will develop hormone refractory disease. Okay. Well, basically, what that means is with time, the anti-testosterone therapy isn't going to work. So with androgen deprivation therapy, the aim is to try to keep the testosterone as low as possible. Back in the day, they would cut off your testicles to remove that testosterone source. But now we have medical options, Lupron, Firmagons. There's even anti-testosterone agents. You can do a combination of them. These agents, the LHRH, that means luteinizing hormone releasing hormone agonists, these work centrally in the brain. Okay, whereas anti-estrogen, they kind of work at the level of the actual organ. So really, this is kind of a schematic of prostate cancer when it occurs. Starts off, you have a PSA that comes up. Okay, this initial diagnosis. You get treated, the PSA comes down. Now the PSA is coming up. It's called biochemical relapse. Okay, because now we're finding something on the blood test. What happens is patients get androgen deprivation therapy, Lupron, controls the PSA initially for many, many, many years. But at some point, it runs out of efficacy. Now, what happens is patients are hormone refractory. They have to take second-line hormonal therapy. And at some point, a consideration of chemotherapy also. Okay. So when do you start the Lupron therapy? There's no good consensus. Okay, most oncologists that I know will wait for the PSA to reach about 15 or 20, okay, before they start Lupron therapy. You should start if there's evidence of metastasis. If a patient comes in, there's bone mets, yeah, you should start on Lupron probably right away. Okay. The side effects are very bothersome with hormonal therapy. Okay. Hot flashes, osteoporosis, fractures, obesity, insulin resistance, increased cholesterols, higher chance of heart attacks. Okay. Who's ever experienced a hot flash before? Yeah, they're not pleasant. Okay. You know, many men ask me, what can I do for hot flashes? And I saw it was asked in the previous talk too. You know, some people will say, take an SSRI, take this or that. But actually, one medication that's very good for hot flashes is actually estrogen. It's what women take for menopausal hot flashes. I've had several men on that from who have hot flashes from Lupron. Works very, very well. So if you have hot flashes, you always try estrogen. It's in any supermarket or Walgreens store. Generally, it's very safe. The only thing they say is if you're on Coumadin, watch out for the levels. They may lower your Coumadin levels. Okay, but it's remarkable. My men love it. The one who have hot flashes. Now, how long should we give the medication? There's two ways to give the Lupron. You can give it when needed, when the PSA starts to go up. Or some people of the more old school believe that you got to give it every 3 months. You got to control things. Okay. I'm in the arm where I think intermittent is better. Okay. If one injection controls the PSA for many, many, many years, why give another one? Okay, I had actually one patient, Gleason 9 cancer, 89-year-old gentleman. His PSA was coming back after radiation. I actually gave him one 3-month dose of Lupron and actually controlled his PSA for 2 years. Okay. His testosterone was low, never recovered. Okay, so some men who are older, even though we say we give you 3 months of Lupron, it's going to last maybe 6 months, maybe even more. Okay. And you know, I kind of think of the Lupron therapy. It's kind of like tools. The quicker you use your tools, and you use all of them, then you have no more tools to use afterwards. So you want to use them sparingly. Now the patient is starting anti-testosterone therapy when his PSA reaches 18. They do a bone scan MRI, it's negative. He's given intermittent Lupron therapy and actually controlled him for 2 years. That's pretty good. His PSA is always around 0.3. In 2014, his PSA starts to go up and reaches levels of 35, despite having his testosterone levels less than 50. Okay. So this is a definition of castrate-resistant prostate cancer. Now this cancer is immune to Lupron. Okay. Definition is 2 to 3 consecutive rises in the PSA levels obtained more than 2 weeks apart. Your testosterone needs to be less than 50. Or if you have disease progression on CT, bone scan, obstructive wing symptoms. Okay. So there have been cases where I've seen patients, PSA is low, okay, yet they have this progressive disease in the bone. And that most likely means, there's 2 types of cells, 2 types of prostate cancer cells. One that's making PSA, the one that's not making PSA. The ones that don't make PSA are normally the ones that are very, very mutated prostate cancer. They're so mutated, they can't even make PSA. Gleason 10 cancers, commonly, upon diagnosis, they have a PSA of 1.5, yet they have spread throughout the whole body. So I kind of want you to think of, the blue stars are hormone-sensitive cells, the red stars, hormone-resistant cells, okay? Because there's many thoughts on how do you become hormone-resistant. There's some thoughts that, hey, perhaps these hormone-sensitive cells learn and become hormone-resistant. There's other thoughts that, hey, perhaps at the get-go, there's already these hormone-resistant cells. So when you give the hormones, yeah, you suppress all the blue hormone-sensitive cells. But then after that, these hormone-resistant cancer cells take over. Okay? And now you got a bigger problem. Okay. So how do we approach castrate-resistant prostate cancer? Most oncologists, urologists will maintain the castration, keep giving the patient Lupron. If they're asymptomatic, negative imaging studies, or a slow PSA doubling time, then we can start on a second-line hormonal therapy. If they're symptomatic, just think about doing docetaxel, or even something called Xofigo. These are some of the second-line hormonal therapy agents: Zytiga, Xtandi, ketoconazole, DES, corticosteroids, and also anti-androgens here, non-steroidal. Here's Kazax, flutamide. And this is abiraterone. You take 4 tabs once daily. It's an androgen synthesis inhibitor, so it works at the level within the cell. And this you have to take it with steroids. Okay, the reason being is with the abiraterone, because it shuts off the testosterone supply in the adrenals. Okay, what happens is you start making more corticosteroids, so your body makes more steroids. So you actually give the patient external prednisone, and that will actually shut off the patient's own corticosteroid synthesis. So that's why you have to take the steroids with this. You have to monitor liver functions, test potassium, phosphorus once a month, and monitor blood pressure once a month. Most common side effects are fatigue, back and joint pain, peripheral edema, hypertension, and serious side effects include liver, heart problems. Enzalutamide is an anti-androgen. Okay, it inhibits signaling of the androgen receptor at multiple levels. This one you don't have to take prednisone with it. Okay, less side effects than the abiraterone. Okay, commonly given with GnRH agonists. Okay, and serious side effects, seizures, but although very rare. So a patient undergoes Zytiga therapy. PSA decreases to 15 over a period of 9 months. Okay, so it looks like you controlled it for a while. Then it goes up to 50. Now we know the cancer is resistant to the Zytiga. So now we got to switch agents. Next one they do, Xtandi, okay, enzalutamide. There's no magic or key in which one comes first. Some med ops will say, hey, do the Xtandi first. Some will say, no, do the Zytiga first. At some point, most men will take both of the therapies. Now the patient's on Xtandi. PSA goes down from 50 to 10 over 6 months. Okay. Patient now notes he has new onset low back pain. Pain worsens daily. Every day it's worse and worse. Pain initially responds to Motrin, but now it's 8 out of 10. Okay, so now we order a bone scan. Okay. Now we see this is a typical bone scan. You have a little outline of the skeleton right here. These dark areas, okay, are areas of uptake or activity. Okay, it shows that there's metastases here. Okay. Patient receives external beam radiation to the upper thoracic spine. In 2 to 3 weeks, his pain is completely gone. So with external beam radiation, it's that same machine I treat the prostate with, okay, except I'm pointing at the bones and treat it 10 fractions, okay? Most of the pain relief actually happens after the radiation's finished, okay? About 2 to 3 weeks, it's completely gone. Now, the number one most common place prostate cancer likes to go to is the bones, okay? So it's not the liver, it's not the lungs, it's the bones, okay? And in vitro data shows that, prostate cancers, there's a preference for it to colonize within the bone tissue, okay? Mostly driven by chemo attraction. Prostate cancer meds also associated with osteoblastic activity. So whenever there's bone involvement, there's either osteolytic or osteoblastic. Lytic means it's actually destroying the bone, icing the bone. Blastic means there's more bone being made there, but made in a disorganized fashion. Okay? So that's why the balance of, there's always bone destruction and bone deposition going on. But now with mets, there's more bone deposition. Okay? Patients also have a higher level of alkaline phosphatase. So the most common site of prostate cancer spread is the bones, okay, about 90% of the time. Nodes, visceral organs like liver, much less. 46% of men with castrate-resistant prostate cancer will develop bone mets within 2 years. Okay, so if you look at this, the longer and longer time goes, more and more men actually have it spread to their bone. So by the time it's 5 years, 60 months out, it's close to almost 70%. And bone mets are associated with shortened survival. Okay, so in this study, they kind of looked at time after initial prostate cancer diagnosis and probability of survival. Okay, this line up here are patients with no bone metastases. This one down here are patients with bone metastases. So it shows you that the ones without have a much higher chance of survival. The ones with it, lower chance of survival. And also skeletal tumor burden is an independent predictor of death. So if you have more mets, it basically signifies perhaps a worse prognosis. So a patient continues to take their second line hormonal therapy, Xtandi. PSA is controlled at 10 for several months. He then develops worsening back pain and hip pain. So we say, hey, gotta get another bone scan, see what's going on. Oh, what do we see here? Now it's involving the ribs, lower spine, upper spine. Right here, the femur is involved. There may be some activity in the pelvis. So this is progressive symptomatic mets. Okay, there's a lot of areas right here. You know, it's too many areas to treat by external beam radiation alone. Okay, for me to treat all these sites, 1, 2, 3, 4. There's over 10 sites here. It's much too much external beam radiation. We need something that can cover the whole body, something that's more systemic. Okay? And that's where Xofigo comes in. Okay? It's a very excellent medication for decreasing the pain from bone mets. Okay? The second option is chemotherapy. But Xofigo is indicated for the treatment of patients with castrate-resistant prostate cancer. Okay? So you have to be castrate-resistant prostate cancer. I had one man, newly diagnosed, still hormone sensitive, he was spraying with Lupron. Couldn't get this approved because he was not castrate resistant yet. Okay. And also no known visceral mets, so no lymph node mets within the abdomen, nothing like no spread to the liver. Okay. Contraindicated in women, okay, but they're doing trials in breast cancer, but for women don't have prostate. But basically how Xofigo works is it's a radioactive isotope of the alkaline earth metal radium. And it actually mimics calcium. So if you look at your periodic table, okay, calcium and radium, they're the same column. Okay? So it actually forms complexes with the bone and actually goes to areas of increased bone turnover, okay, where there's more blastic activity. Now, the way this works is it emits an alpha particle. There were previous agents in the past like samarium, strontium. Those were beta emitters. So those actually traveled quite far. So when it goes to your bones, it has a higher chance of suppressing your marrow because it's giving off radiation to a farther distance. But this alpha particle is a very short range, only about 10 cell diameters. Okay? So this really limits the damage to the surrounding normal tissue, basically the bone marrow. So with this agent, there is some decrease in your white blood cells, red blood cells, but very mild. Normally the dip happens about 4 to 6 weeks in the treatment. Afterwards, it just goes back up. And the Xofigo emits alpha particles that predominantly cause double-stranded DNA breaks in adjacent cells, resulting in an anti-tumor effect on bone metastases. And Xofigo can be absorbed by other organs other than the bone, primarily the bone marrow and GI tract. Okay? And actually, it's excreted through the GI tract, so you actually poop it out. Let's see here. Yeah, so one of the cautions with it is because your urine, feces, and vomit are now considered radioactive. So some precautions we tell patients afterwards is when you urinate, okay, if you hit the toilet bowl, you know, wipe it with a tissue paper and throw that tissue paper away. Don't use a rag, okay. If you have soiled clothing, you know, just go ahead and throw them away, okay, because they are considered radioactive. Okay. Let's see. This one isn't too long. Yeah, basically this one's just saying that after 10 minutes after the injection, the radioactivity is observed in the bones and in the intestines. After 15 minutes, 20% of the injected radioactivity remains in the blood. At 4 hours, 4% of the injected radioactivity remains in the blood. So it gets out of your system pretty quickly. Okay. 61% and 49% of radioactive dose present in the bone and intestine respectively. At 24 hours, less than 1% is remaining in your blood. Okay. And fecal excretion is the major route. 63% excreted within 1 week, okay, and less than 5% excreted through the urine. Now, the interesting thing about this agent is that there is actually an overall survival benefit, meaning men are actually living longer from this. okay? Which they didn't see that with Sumerian or strontium, okay? Those were just palliative tools to help kind of relieve pain. But with this, they found out men were actually living several months longer than the ones who didn't get it. So right here you see 11.3 months placebo, 14.9 months with the Xofigo agent. Okay? 30% reduction in the risk of death. Okay? So it doesn't mean it's going to cure you or prevent you from dying in the end, but it just meant when compared to placebo, less patients were dying. So some patients who get this, they've had chemotherapy before. So this slide illustrates that. Thrombocytopenia, which is lowering of the platelets. If you haven't had chemo before, only 1% chance of having thrombocytopenia. With prior exposure, just 4%, not much higher. Neutropenia, which is lowering of your neutrophils. Okay. 1% if you've never had chemo, and only 3% if you've had. So very, very little. And basically what they found, as I talked to you earlier, was reduction in death, 3.6 month increase in median overall survival compared to placebo. Because of the potential for bone marrow suppression, okay, hematologic evaluations performed at baseline and prior to every dose of Xofigo. Most common adverse reactions in the Xofigo are more nausea, diarrhea, and vomiting. Okay. If you see, compared with placebo, not much. Okay, 36 versus 35%, not much, only 1% increase maybe. Diarrhea, maybe 10% more. Vomiting, maybe 5%. So overall, very, very well tolerated medication. This is just some other information. You know, whenever you have bone metastases, most of them are on hormonal therapy. Okay. ADT is associated with increased risk of fracture, decreases the bone mineral density. Longer treatment increases your fracture risk. And the NCCN recommends that men who are on ADT get supplemental calcium, vitamin D, baseline DEXA, then 1 every year. There's agents that can also strengthen the bone, like Zometa and denosumab. So this is just a kind of an outline of the medications, when they're used at what state. So I mean, patients, they start from hormone sensitive, castrate resistant, and they become metastatic. And this is kind of the order of medications. Most patients with advanced cancer, they will probably see all these medications. Okay. Now the patient finishes 6 cycles of chemo, his PSA actually drops down. Okay, so Xofigo will actually lower your PSA. His pain's completely resolved. But now 3 months later, his PSA increases to 50. Bone scan now shows worsening metastasis. Now it's all over the place. Okay. Now we think, well, what more can we offer? He responded so well to the Xofigo, we should repeat it. We'd like to try it again. However, it's only approved for 6 cycles right now. Okay. Right now they are doing research at USC, looking at adding on 6 more cycles of Xofigo after the initial 6, combining it with other anti-testosterone agents, seeing if that will give a better response. So that's the active research that's going on with the Xofigo. So most likely in the future, I mean, this medication is probably going to be given for more cycles than 6, perhaps 12, perhaps even more than that. Okay. So because of that, the patient now proceeds to chemotherapy to help control things. The main chemotherapy that's used are Taxol agents. Okay. These bind to the microtubules, okay, reversibly with high affinity. They basically stabilize microtubules and prevent depolymerization. So what that means is cancer cells, when they divide, okay, this is from college biology. You have a cell here, okay, then the nucleus kind of separates to different edges. Then the DNA replicates. Okay, then these microtubules actually separate the DNA, so they go into cell number 1 and cell number 2. But with the docetaxel, they stabilize these microtubules, so now they can't pull the DNA into the cell, so it prevents the cell from actually dividing. Okay, so that's how the docetaxel works. Now, this new study just came out recently. This is probably the most interesting thing, is that in patients who are hormone sensitive, okay, because remember, normally chemo's for the hormone resistant ones, but now there's data that patients who are hormone sensitive with metastatic disease, if you administer chemotherapy along with the androgen deprivation therapy, you can actually increase a man's survival over androgen therapy alone. So patients who had ADT and docetaxel had a 3-year survival rate of 69%. Ones who had ADT alone, 52.5%. So this is really practice changing. Now all the medical oncologists, they want to see the patients sooner. Okay? They don't want to see the patients at the end after they've maxed out the hormones. They want to see, are there patients here who can possibly benefit from the chemo up front? And it's probably the same thing as I talked about earlier is that initially, you have these hormone-sensitive cells, and you may have these hormone-resistant cells. Perhaps giving the chemo up front with the ADT, now I can kill off everything from the get-go. I'm not just killing off one, letting the other overgrow, and then trying to kill off the other guy. Okay, so it may be that further research is going to be more into combination therapies, perhaps taking the Zytiga, expanding Lupon all together with chemotherapy, but more and more studies need to be done to really see if that's really going to affect anything. So yeah, that's it. These are just future research. We're looking at when should certain agents be used, what timing should we do things. Okay, should some agents be used together? Does early chemotherapy help with primary treatment in newly diagnosed prostate cancers, especially men with aggressive prostate cancer? And new agents are always under development and research. And this is just a picture of Tokyo. I'll be going there next week, so my mind's looking at Tokyo right now. Anyway. So that's the end of my talk. And I'm wondering, are there any questions, concerns?
If you have any questions, please raise your hand, and I'll give you the microphone so that we can get it on the table. Anybody? Oh, didn't see you hiding over here.
Thank you. I had one question. You talked about some cancer cells don't give off PSA and some do. Maybe give a little more explanation on that.
Yeah. So what can happen is in Gleason 10 cancers, the one with the grade 5s in them, the mechanism for making the PSA is lacking because that cancer cell is so mutated that it can't even make the PSA anymore. What happens is when you look underneath a microscope, you see very circular glandular structures in a normal prostate. Okay, they form these circular glands. The more and more mutated the gland becomes, it actually doesn't form circular glandular structures. It forms these linear-looking patterns. Okay, and those type of cells are very mutated. They just don't make any PSA. So it becomes difficult to diagnose Gleason 10 prostate cancer. Most of the time, those men are diagnosed when they get the bone mets. Okay, they have pain. They do an MRI. Looks like there's a bone lesion. They biopsy. They find it's prostate cancer. So those ones are extremely dangerous. Yeah.
Normally high associated with high PSA or high Gleason.
High Gleason score, yeah. High Gleason score, yeah.
You were talking about ADT along with chemo combinations, but it seemed like the study was based on somebody starting at the get-go as they get on the hormone therapy, they actually then start the radiation.
Radiation or chemo?
I'm sorry, chemo. So assuming that they already have radiation. So what about if somebody has already been on hormones, he's hormone naive, everything's fine, and he says, you know what, I'd like to start chemo alongside. I don't know if there's been any studies on that, but it would seem like it might have some potential positive effect, even though they didn't start at the same time they started ADT.
Yeah, there may be. I agree with that. So, are you asking from where you said hormone naive men who've had hormones or not hormones?
No, people who the hormone therapy is still working.
Still working, hormone sensitive. Okay.
Right, and so that they can keep taking it until it fails, or they go on, for example, Zytiga, or they're taking it, and at the same time they go on chemo.
Yeah.
And I don't know if there's any studies. It seems like the study that was done was strictly for people who started all at the same time.
Yeah.
ADT as well as, but has there been any other studies that show, well, no matter when you started, if you're still sensitive to the hormone treatments, that they recommend you go on chemo as well, because they think it would have an effect.
Yeah. So very little data, but it does make sense though, right? Getting the chemo in earlier. So theoretically, I think there may be some benefit, but just more studies need to be done for us to really prove it.
I understand that the variant equipment what you have with UCI is new to you, is that correct?
Oh, so I'm from the Cancer Center of Irvine. We're completely separate from UC Irvine. So we've had this linear accelerator for a while, but you know, we had it for about 10 years. So we've had it for a while, you know.
Is that the variant?
The Variant, yeah, the Variant. So there's two major makers. There's Variant and Electa. The one machine we use is Variant's.
What's so different about the variant of this?
You know, it's like having an iPhone or a Samsung. You know, they pretty much do the same thing. But it depends on what brand you prefer. Variant has the larger market share. You know, I think about 80% of the market's Variant, 20% is probably Electa.
My next question is, what kind of bone scan do you think is acceptable to you in best determining the future?
Yeah, that's a very good question. So there's two types of bone scans right now. There's a technetium bone scan, which is the older one. There's also the sodium fluoride scan. So I like the sodium fluoride scan. It's picked up metastases that I didn't see on technetium scans, which is important because if you have a patient who has a recurrent prostate cancer, you kind of want to know if it's gone to the bones or not. Okay, so there's been cases where I send a patient for a technetium scan, shows nothing. Okay, we do a sodium fluoride scan, and yeah, there's microscopic disease actually all over the place that lights up. So I prefer the sodium fluoride scan.
Is that done at UCI?
I'm not sure if UC Irvine does it. When I have the sodium fluoride scan done, I'll send patients out to Long Beach Memorial or Saddleback. They do the sodium fluoride scan.
Wow. I guess we wrapped up the questions. You know what? I know why there's not a lot of questions. Because your talk was very, very inclusive and comprehensive. It wasn't all that, everybody could understand what you were saying. And your slides were very good. I really enjoyed the talk. Thank you very much, Doctor.
Thank you.
Now, we all know that we operate on a very limited budget here. So we can't afford to pay you a lot of money, but a doctor's time is his money. So we can save you some time. We've got this modified cup to fit in your car so that you can drink your coffee on the way to work. You don't have to sit at home and drink your coffee, saving you time and money.
Yeah,
Thank you very much, Doctor.
Thank you.
We appreciate it.
Take care, everybody. Drive safely. I'll see you guys at Choosing for a Cure on Saturday.
Okay. Yeah, driving